Welcome to Unit 7, and our first chapter for this unit is Chapter 16, which discusses fluid and electrolyte replacement. The first concepts we need to talk about is just the overall control of fluid and electrolytes in the body, and that balance is maintained by the kidneys, the lungs, the endocrine system, the gastrointestinal system, our skin, and et cetera, et cetera. A basic principle is that our intake and output from all sources must be roughly equal. And that is going to help us maintain fluid balance. And the body constantly strives for equilibrium. We lose fluid through our breathing and our skin too. And in general, we lose about 2.6 liters per day. So we need to take in about 2.6 liters per day. And that's a combination of food and liquids. Now, if we are hyperventilating, such as with exercising or when sweating a lot on, for example, a hot day, we will need more fluids to replace what is lost through our skin and respiration. There's also the total body water, and that's two different types. There's intracellular fluid, and that's the fluid inside of our cells, and there are extracellular fluid. That's fluid outside of the cells, and that includes interstitial fluid, intervascular fluid, that is the fluid that's in our veins and arteries, and that's where the majority of our fluid rests at. Along with fluid balance, electrolytes play an important role. Electrolytes are substances that separate or dissociate in ions when they're in a solution. They are in both the intracellular fluid and extracellular fluid, and they can either carry a positive charge or a negative charge. Electrolyte balance is essential for normal physiological functioning, and it's closely linked to fluid balance. Many illnesses and body system problems can cause electrolyte imbalances, which need to be corrected quickly before serious problems or even death can occur. The major electrolytes that we're going to focus in on in this PowerPoint are sodium, potassium, calcium, and there are others. There's magnesium, chloride, phosphorus, sulfate, hydrogen and bicarb, and proteins. An important skill that nurses do is we administer IV fluids and electrolytes replacements, and a lot of times this can be thought of just routine nursing care, but administering IV fluids and electrolytes requires a lot of care and diligence and critical thinking about, does it make sense for a patient in this particular condition to receive this particular solution. There are two principles that stand out when considering homeostasis and fluid and electrolyte balance. The first principle is that positive and negative charged ions need to be balanced within each compartment and remain electrically neutral. The second principle is that fluid compartments must remain in osmotic equilibrium, so in balance. There are a number of processes that help control the movement of fluid and particles between and within compartments. Just a few examples are osmosis, diffusion, membrane transport, hydrostatic pressure, membrane permeability, colloid osmotic pressure, and the size of the particle, to just name a few. So from there, we talk a little bit about the fluids, the body fluids, and two terms that we use to refer to the number of particles or the concentration is osmolality and tonicity. Osmolality speaks to the body fluids, and that's basically the number of particles that are dissolved in the body's serum. And particles include things like potassium, sodium, urea, and glucose. And it's used in reference to body fluids. So there's isoosmolar, hypoosmolar, and hyperosmolar. And the definitions are listed on this slide. And then there is the idea of tonicity, and that's used primarily as a measurement of the concentration of IV solutions when they are compared to body fluids. We're going to talk about classifications of IV solutions, specifically crystalloids, in a moment here. These are important concepts to understand, and we're going to talk about them more next. Just another caution on fluid balance. Water intake should be about 3.7 liters for men, 2.7 liters for women. Remember, we talked about water loss, and there's actually two different types of water loss that nurses should be familiar with. One is sensible water loss, and that is what is measurable. What can we measure? We can measure urine output, and if it's liquid stool, we can measure feces. Then there's insensible water loss. That's water loss that we cannot measure. And again, that's going to be perspiration, respiration, so the skin, the lungs, and then if a stool is solid, there's also water loss through that feces as well. IV fluid replacements are ordered based on an assessment of the patient's fluid and electrolyte balance, their fluid requirements, and their fluid needs. So questions to ask about IV fluids is, what we're infusing, is that for replacement or maintenance? What are the patient's water, electrolyte, and protein requirements? What are the patient's weight, caloric needs, and body surface area? An example would be taking into consideration a patient who has acute illness or is a surgical candidate. Those are instances where the patient's needs are going to be different than those from a healthy person that's able to eat and drink normally. Another important thing about fluid replacement is to make sure that you don't overhydrate patients. If the patient is overhydrated, they can develop fluid in their lungs, which is known as pulmonary congestion, and that's a serious problem that we would need to treat with medications. In patients that need fluid, one classic symptom is a low blood pressure with increased pulse rate. The pulse is going to be increased because the heart's trying to compensate for the low blood volume. And once we give this patient with a fluid deficit IV fluids, the heart rate will decrease and the blood pressure will increase, normalizing. So, like I said, we're going to talk a little bit more about classification of IV solutions next, specifically crystalloids. There are three general classifications of IV solutions that are used for fluid replacement, and they are crystalloids, colloids, blood, and blood products. So let's first talk about crystalloids. Crystalloids contain fluids and electrolytes, and they are able to freely cross capillary membrane walls. They are used to treat dehydration and electrolyte imbalances and as short-term maintenance fluids. There are different types, and this is an important concept that you understand. The first is isotonic, and that is the same tonicity of the extracellular fluid or plasma. And examples of that are normal saline, lactated ringers, and 5% dextrose. There are hypotonic, so they are less osmotic or lower tonicity, and that is going to allow for water to move into the body cells. And examples of that would be 1/2 normal saline or 2.5 dextrose. The third type is hypertonic. Those are more osmotic or have higher tonicity than the extracellular fluid, and that allows water to pull out of the cells. Some examples of that, basically as a general rule, if you have any type of D5 or greater paired with another solution, it's hypertonic. So D5W, 1/2 normal saline, D5W with normal saline, D5W with LR, and also the D10 and D50s. As I mentioned, another category or classification is the colloids, and those are known as blood volume expanders because they contain large proteins and other large molecules which draw fluid into the intravascular space, and that boosts the circulating blood volume. An example of that would be HESPAN. There are also lipids. Those are for people that are NPO or people that have had no enteral feedings for greater than 7 days. And those are generally given with TPN. And we're going to talk about TPN in an upcoming chapter. And then lastly, there's the blood and blood products. Blood products can include things like red blood cells, platelets, plasma, cryoprecipitate. And for any type of IV solution, you always check the compatibility prior to starting an infusion. This is just another touching base of the crystalloids because it is so important to understand and know these. The isotonics, we're going to use those for rehydrating after vomiting. They correct dehydration, and they can also correct sodium depletion. They have the same serum osmolality as the extracellular fluid or plasma. There then is the hypotonic. Common use for that is correcting intracellular dehydration. Many times a common condition associated with that is diabetic ketoacidosis. And so this is going to correct intercellular dehydration and provide fluid for the excretion of body waste. We don't use this if a patient has increased intracranial pressure, if they are experiencing shock, liver disease, or trauma. And again, fluid is going to move into the body's cell when you give a hypotonic solution. The third type is hypertonic, and that is used to increased intracranial pressure related to cerebral edema, and that is going to allow fluid to leave the cell, which helps with the edema and lowers intracranial pressure. We tend not to give this outside of critical care areas, so this would be something we would give in the ICU. And it has to be very cautiously monitored. We don't give this with DKA. We don't give this for dehydration. So really, isotonic is what you're going to most commonly see given. And then the fourth category is the colloid, and we use that for in severe shock, and that is to increase blood volume. This slide is just a little bit of a picture of the different fluids and what they're used for to help you with that. Just to touch base on blood and blood products again. We use these only when necessary, and typically the type that we give is packed red blood cells. It's more frequently used than whole blood. We can also give plasma, and we can also give albumin, which is a type of colloid. But again, these are high-risk medications, and we will get into more details into the rules and regulations in blood transfusions next term. I do have a few things I want to touch base on. For a blood transfusion, the maximum amount of time for 1 unit of blood is 4 hours, and that time starts when the blood product is removed from the refrigerator in the blood bank. So from that time, we have 4 hours to infuse it. If there's blood left over once the 4-hour mark hits, we have to get rid of it. We cannot infuse it. We must have the correct blood type and cross before infusing. Know that whole blood or packed red blood cells will raise hemoglobin by 0.5 point to a point and hematocrit by 3 points. Many times we give loop diuretics with blood transfusions to help prevent fluid overload because each unit is anywhere from 350 to 500 milliliters of fluid. With multiple blood transfusions, we need to monitor serum calcium levels because they can go outside of the normal range. And we also must monitor for transfusion reactions. The most important vital signs is temp, pulse, BP, oxygen, and respiratory rate throughout the transfusion. And by infusing packed red blood cells, we're going to also include an increase in the oxygen carrying capacity. And so that is an important consideration as to why we actually give blood many times. This is a slide that just shows you the most common types of transfusion reactions. And usually if you're going to have a blood transfusion reaction, it happens within the first 10 to 15 minutes of the transfusion. So this is why we get a set of baseline vitals before we start. And then 15 minutes in, we get another set of vitals. And what we're assessing for are these type of reactions. Now, going back to electrolytes, and that's what we're going to talk about for the remainder of this chapter. This slide has the normal lab values for these electrolytes, so I would definitely know these. The top three are the potassium, sodium, and calcium, and that's what we're going to learn a little bit more in depth. For potassium, the normal range is 3.5 to 5. It is an intercellular ion, and if you have hypokalemia or low potassium, you could have specific signs and symptoms like fatigue, muscle weakness, irritability, confusion, drowsiness. You can have heart arrhythmias, and or thready pulses. You can also have nausea and vomiting. And on the flip side, if you have too much potassium or hyperkalemia, a lot of times you're going to have muscle cramps, urine changes. You can have respiratory distress or EKG changes. For hyperkalemia, there are certain medications that we're going to give, and for hypokalemia, again, there are certain medications, and we're going to talk about these next. So if a patient needs potassium replacement due to low potassium, we are going to give it either orally or IV, but either route must be diluted, because if we give potassium too fast, it can cause fatal hyperkalemia and kill your patient. Oral replacement is appropriate for slightly low potassium levels, and we dilute oral potassium with water or orange juice and then follow with a large glass of water. IV potassium is indicated for larger abnormalities in lower potassium levels, so acute or moderate to severe deficiencies. Again, it must be diluted, and there are some maximum infusion rates that you need to know. The peripheral IV maximum infusion rate is 10 milliequivalents per hour. For central lines, it is a maximum of 40 milliequivalents per hour. Again, you do need to know those values. And then if your patient has high potassium or excess potassium, we expect to administer K-oxalate, or we can give sodium bicarbonate, calcium gluconate, or a combination of insulin and glucose to help get rid of that excess potassium. The next electrolyte I'd like to talk about is sodium, and its normal range is 135 to 145. It functions in the extracellular fluid, and if you have low sodium or hyponatremia, you could have signs and symptoms such as nausea, vomiting, abdominal cramping, lethargy, headache, and that could progress to seizures, respiratory arrest, or even coma. If you have too much sodium, that's hypernatremia, and that's where in the upper right-hand category, the flushing of the skin, a low-grade fever, thirst, you can have increased blood pressure and fluid retention, and decreased urine output. One general category of food that is notoriously high in sodium are canned foods. So if your patient has high sodium levels, we definitely want them to avoid eating canned foods. Next is the third electrolyte that you should be familiar with, and that is calcium. Calcium's normal range is 4.5 to 3.5, and there's also the ionized range, but I would remember the 8.5 to 10.5. Quite honestly, that's probably the most commonly referenced normal range. So again, calcium, I would remember the 8.5 to 10.5. It is in the intercellular and extracellular fluids. If you have low calcium, you can have convulsions, tetany, cardiac arrhythmia, and stridor and spasms. If we need to give calcium, we can give IV or oral calcium, and oral calcium must be taken with vitamin D 30 minutes before meals. If you have too much calcium, you have hypercalcemia, and some signs and symptoms of that would be muscle weakness, decreased deep tendon reflexes, anorexia, nausea, vomiting, arrhythmias, and it could progress to heart block. What we do for too much calcium is we treat it with calcitonin or IV fluids rapidly infused and followed by a loop diuretic so that we pee out the excess calcium. There are certain medications that can cause calcium abnormalities, and those include phosphates, loop diuretics, aspirin, anticonvulsants, and corticosteroids. And an important side note is that anytime we're going to give IV calcium, we need to assess the patient's renal function because IV calcium contains aluminum, which is toxic if the kidneys aren't functioning properly. We also want to be careful with IV calcium if the patient is taking digoxin because increases in serum calcium can increase the risk of digitalis toxicity. And just to touch base, calcium and phosphorus have an inverse relationship, so that's important to remember. So if you have high phosphorus levels, you will have low calcium levels, and the opposite is true. If you have high calcium levels, you're going to have low phosphorus levels, and that's because they have that inverse relationship. And that brings us to the end of our first chapter. Thank you for listening, and we'll pick you up on chapter 17. Okay, welcome back, and this is chapter 17 where we discuss nutritional support. And let's first talk about nutritional needs. Nutrients are needed for cell growth, cellular function, carbohydrate, fat, protein synthesis, muscle contraction, wound healing, for our immune system to work properly. And inadequate nutrient intake can result from surgery, trauma, having a malignancy, or other catabolic illnesses. Without adequate nutritional support, protein catabolism or breakdown, malnutrition, and diminished organ functioning will affect the gastrointestinal, hepatic, renal, cardiac, and respiratory systems. The functioning of the immune system will also be decreased. Patients who are well nourished can generally tolerate a lack of nutrients for about 2 weeks or 14 days without major health problems. However, patients who are critically ill may only tolerate a lack of nutrient support for a short period of time, i.e., a few days to a week. And then they will start showing signs of impaired organ function, infection, or morbidity. For both critically ill and for patients with major injuries, early nutritional support improves intestinal and hepatic blood flow and function, enhances wound healing, and decreases the occurrence of infection, which is going to improve the general outcome of their health situation. Generally speaking, a patient requires about 2,000 calories per day. Critically ill patients can require 3,000 to 5,000 calories per day. For individuals who have extensive burns, the caloric need could be even greater. And patients who are nothing by mouth or NPO for an extended period of time will become malnourished. So keeping that in mind, there are 2 routes for administering nutritional support: enteral and parenteral. Enteral feedings, enteral nutritions, those involve the GI tract, and they can be given orally or by tube feedings. Use of a nasogastric tube through the mouth or nasal cavities are the most common route for short-term enteral feedings, and we're going to talk more about enteral feedings. The components of an enteral feeding includes carbohydrates, protein, and fat. Enteral feedings require adequate small bowel function with digestion, absorption, and GI motility. To determine GI motility, we must listen for bowel sounds and assess for the presence of bowel movements. There are a variety of different formulas and delivery methods that offer various nutritional benefits. For example, with the bolus method, 250 to 400 milliliters of enteral solution is rapidly administered through a syringe or a funnel into the tubing food 4 to 6 times per day. This bolus method takes about 10 minutes for each feeding, and it may not be tolerated well by patients because a massive volume of solution is given in a relatively short period of time. The additional method is infusions, and that can be through an intermittent enteral feeding, and those are given every 3 to 6 hours over 30 to 60 minutes by a gravity drip or a pump infusion, and usually at each feeding about 300 to 400 milliliters of solution is given. There are continuous feedings, and those are typically prescribed for critically ill patients or for those who receive feedings directly into the small intestine. Enteral feedings are given by continuous feeding are given through an infusion pump at a slow rate over 24 hours. And then the other method that's listed on the slide is the cyclic method, and that's another type of continuous feeding, but it's infused over 8 to 16 hours daily, and that can be either during the day or at night. There are some complications that you need to be familiar with enteral tube feedings, and that includes dehydration. And how do we prevent that? We give this patient water through their tube feeding between feedings to make sure they have adequate water intake. Another risk is aspiration. What are we going to do to prevent that? We're going to keep the head of the bed at 30 degrees or higher during and for 30 minutes to an hour after tube feedings. And there's a risk for diarrhea. And what are we going to do to prevent that? If we notice some loose stools, we're going to slow the rate of the tube feeding infusion and notify the prescriber. So some additional important nursing considerations for you to be familiar with are the head of bed must be 30 degrees or higher. Slow your infusion rate for diarrhea and notify the prescriber. Monitor for signs and symptoms of dehydration. You need to complete a good assessment. Assessment of bowel sounds, bowel movement, assess for abdominal distension, nausea, vomiting, or a feeling of fullness. The nurse should check for gastric residuals. We should check before every feeding and every 4 hours. And how we do that is by gently aspirating the stomach contents before administering the next feeding. And if the volume aspirated is 100 milliliters or more than 2 hours worth of feedings, we would hold the feeding and notify the prescriber. There is some safety steps. There is the alert safety. So A is for aseptic technique. L is label enteral equipment. E is elevate the head of the bed. R, make sure we have the right patient, right formula, and right tube. And T, trace all lines and tubing back to the patient. Another important idea is what is aseptic technique. So it's clean, not sterile. We would be sure to wash our hands and wear gloves. We should not hang formula for more than 24 hours because bacteria could grow and cause the patient to become sick. We want to make sure we have the right formula. There are specific formulations for specific patient needs. For example, if a patient has renal problems, there are enteral tube feeding solutions specifically for those patient populations. Let's see, for enteral medications, we've talked about this already in lab. But liquid medication must be properly diluted when administered through a tube feeding. The drug dose is usually given as a bolus and then we flush behind with water. It is essential to know the importance of temporarily stopping the infusion when certain types of medications are administered. Some medications require that tube feedings be stopped for as long as 30 minutes to allow for adequate absorption. And the last thing I want to touch on for this chapter is TPN, Total Parental Nutrition. It involves administering high caloric nutrients through large veins. It is more expensive than enteral feeding, and the benefits are not significant. Enteral feedings, remember, require a functioning GI tract. TPN becomes necessary when the GI tract is not functioning well, either due to things like uncontrolled vomiting, malabsorption, or even an intestinal obstruction. TPN could also be necessary for a patient that has a high risk for aspiration or to supplement inadequate oral intake. In general, TPN is given when the GI tract will not support tube feedings. TPN is built up of vitamins, minerals, proteins, electrolytes, and elements. It can only be given through a central line, not a peripheral IV. A PICC line is an example of a central line. And so because it has to be a central lines are always sterile dressings. And so we need to make sure that that dressing is intact and changed using sterile technique according to policy because there is a risk for infection. TPN is something that does not have fat in it, so you will often see a separate order for lipids to be infused over about an 8 to 12 hour time period. TPN has some complications. I would note all the complications that's listed on this slide, including risk for air embolism, and how we prevent that is by performing the Valsalva maneuver. which is when we take a deep breath, hold it, and bear down. You can also have high blood sugar or low blood sugar. TPN contains a fair amount of sugar, so when we first start it, people can have hyperglycemia, and then when we go to stop TPN, we must taper it, and we can never just stop it because of the risk for extremely low blood sugar. And we need to give the body time to adjust to that. That brings us to the end of Chapter 17 for nutritional support. A lot of important concepts that you should be familiar with, and you'll have an opportunity to discuss some of these points on the discussion board this week. Okay, from here we go to Chapter 47. And these are drugs for gastrointestinal tract disorders. And what are some examples of GI disorders? Well, good old vomiting, diarrhea, and constipation. And drugs that we are going to use, the classes are antiemetics, emetics, antidiarrheals, and laxatives. Let's first talk about vomiting. Vomiting has two different control centers in the brain. And what is vomiting, by the way? It is the expulsion of gastric contents, and it has many different causes. Versus nausea, which is a queasy sensation, it may or may not precede the vomiting. The most important thing is that we figure out what is the cause of the vomiting. Antiemetics or anti-vomiting drugs can mask the underlying cause of vomiting, and therefore they should not be used until we figure out why a patient is vomiting. As I mentioned, it all starts in the brain. There are two different centers in the brain or zones in the brain that trigger vomiting. One is the vomiting center, which is abbreviated VC, and the other is the CTZ. Both of these are important to know because the medications we're going to learn about will affect one of these two centers. We always want to try non-pharmacological measures first when nausea and vomiting occur. If these measures are not effective, then once we know what the cause of the vomiting is, we can use antiemetics. If the patient is trying these non-pharmacological measures and they're not effective and they become dehydrated, then we will use IV fluids to restore body fluid balance. So like I said, with recurrent or prolonged vomiting, the priority is determining what is causing it, offering them support for fluids and electrolytes. We're going to monitor lab values, so their sodium, their potassium, and their renal function, which is going to be creatinine and BUN. We're going to avoid using antibiotics or antiemetics until we know why they are vomiting. What are the different antiemetics that we want to talk about? Well, the first subtype is antihistamines, which we've talked about these quite a bit. Select antihistamines are antiemetics and can be purchased over the counter to prevent nausea, vomiting, and dizziness caused by motion. These drugs inhibit the vestibular stimulation in the middle ear. So that's a little bit different than directly affecting the VC or CTZ zone. We could do non-pharmacologicals in combination with these over-the-counter antiemetics. A side note is that these should be avoided in pregnancy. There are many different prescriptive anti-medications that we can use to help combat vomiting. For example, antihistamines, anticholinergics, etc., etc. And we're going to talk about these in more details. The first ones that we want to talk about are Vistaril, Phenergan, and scopolamine. These work mostly on the vomiting center. They can also decrease stimulation of the CTZ. They have some side effects that are similar to the anticholinergic and antihistamine side effects we've learned about in the respiratory chapter. These medications should not be used in a patient that has glaucoma. The dopamine agonists, the big ones to know is your thorazine, compazine, and Phenergan. They have some side effects of moderate sedation, low blood pressure, some central nervous system effects, and mild anticholinergic symptoms. And these work by suppressing emesis by blocking dopamine receptors in the CTZ zone. And then there's Reglan, which is a very commonly used antiemetic, specifically in like cancer patients, and it suppresses the CTZ center, and it has a few side effects and some reasons not to give it, but it's generally very well tolerated. It can cause sedation and diarrhea in high doses, and we shouldn't give it to anyone that is having gastrointestinal obstruction, hemorrhage, or perforation. And then that brings us to emetics, which are drugs that induce vomiting. And the big one to know is Ipecac. It's available over the counter and it stimulates the CTZ and it induces vomiting. We want to be cautious when we use it, and the best advice I can give you is always call poison control first, because there are some things that are poison that if we vomit, it actually causes damage twice. It would cause damage going down, and it'll cause more damage coming back up. So if you are advised to give Ipecac, use the Ipecac syrup. You take it with a glass of water, not with milk or anything else, and it should induce vomiting within 15 to 30 minutes. If the vomiting does not occur, we're going to give activated charcoal in the emergency room, or we may even need to do gastric lavage if vomiting does not occur. But again, call poison control first. So the next condition we want to talk about is diarrhea. Very, very common patient complaint, and it has numerous causes, as you can see here. And for this, there is also some non-pharmacological measures we want to try. Clear fluids, some oral solutions like Gatorade, or Pedialyte for children. And if that isn't helpful, then we can give IV fluids and electrolytes. And this can cause fluid and electrolyte imbalances because intestinal fluids are rich in water, sodium, potassium, bicarbonate, and diarrhea can cause minor to severe dehydration and electrolyte imbalances. And just like with vomiting, we should determine the cause of the diarrhea before we use pharmacological treatment. So we want to know what's causing it. As a general rule, there are antidiarrheal medications, but they should not be used for more than 2 days. And before we get to the specific types of antidiarrheals, let's touch base on traveler's diarrhea. This is usually caused by E. coli. It usually lasts less than 2 days. However, if it becomes severe, it will need fluoroquinolone antibiotics. We can also use Imodium to slow the frequency of defecation, but by doing this, we can also slow the exiting of the bacteria, and that could prolong their diarrhea. This type of diarrhea can happen when you travel out of the country, and some ways to avoid that is by drinking bottled water and washing fruits and vegetables and cooking everything until it's well done. So now we talk about what are antidiarrheals. So diarrhea is when the body pushes the gastrointestinal contents out very quickly, and so a great deal of water is lost, and it has hypermotility, so fast movement. Antidiarrheals will slow that movement down. And the first type is opioids. And Lomotil is a very common one, as well as Imodium. Uh, Opioids decrease intestinal motility, thereby decreasing peristalsis. And a constipation is a common side effect of opioids. Um, uh, the big difference between Lomotil and Imodium that you should know is that Lomotil can actually cause central nervous system depression. So children and older adults are more susceptible to that, and it can actually cause respiratory depression in them. So be sure to be cautious about Lomotil in comparison to Imodium. Then there are absorbents. So the first group that we talked about, slow peristalsis, these ones serve to absorb the bacteria or the toxins, whatever's causing the diarrhea. So that's how they slow things down. And on the flip side of diarrhea, there's constipation. And there are many different causes of constipation, so we want to do a good bowel assessment. There are non-pharmacological treatments that we should try first. And we should always keep in mind that a normal number of bowel movements ranges between 1 to 3 a day to 3 a week. So what's normal varies from person to person, and it's the nurse's responsibility to assess and determine what normal bowel habits are for each patient. If the patient is experiencing constipation, there are laxatives. They promote soft stool, and there are cathartics and purgatives. Within the laxative type, there are several different subtypes, but most of them stimulate peristalsis, so increases the motility in the bowels. And people can become dependent, physically dependent on these medications, especially older adults, and that's usually from chronic use, and they become unable to have a bowel movement if they're not taking the laxatives. So we do want to be cautious and not give out laxatives excessively. The type of laxatives to be familiar with are Dulcolax and Senecot. Both of those increase peristalsis. Both of them are going to be taken orally. Both of them, you can do a suppository too, but most commonly we give it orally. It usually has results fairly quickly. It's usually well tolerated. Some general side effects is nausea, vomiting, nausea, abdominal cramps, weakness, or even a reddish brown tinge to the urine. Or they could also overreact and actually get a little bit of diarrhea from them too. The more milder type is a bulk forming, so that's your Metamucil, Citrasil, and those help absorb more water into the stool, making them larger and softer. Those take a little bit longer to cause results, but these are the ones that they could take on a daily basis for a long period of time to help prevent chronic constipation. We do have to mix these in a glass of water or juice, stir and drink immediately, and then follow with another glass of water for optimal effect. They're not you can't become addicted to these ones. They're usually well tolerated. Most commonly, maybe some abdominal cramping, gas. If they take too much of it, then you could have nausea, vomiting, and diarrhea. The next type is emollients, which are stool softeners, and that's your Colace or Docosate. And these are very commonly used after surgery or after a patient has a heart attack to reduce straining. And the way that it works is it adds more water, making the stool softeners more soft. And then it also lubricates it so the stool comes out easier. We use these to prevent constipation. Again, these aren't addictive. And they are generally well tolerated. There are some reasons not to give an emollient, and they're listed here on the slide. So I would be familiar with those. And then that brings us to the end of chapter 47. This last chapter, chapter 48, is we're going to talk about anti-ulcer drugs. And the first thing we need to know is, what is ulcer? An ulcer or a peptic ulcer is a broad term for an ulcer that occurs in the esophagus, stomach, or duodenum. They usually occur when there is hypersecretion of stomach acids, and that erodes the mucosal lining. The pH of the stomach should be 2 to 5, and if it increases or decreases too much, that puts the patient at risk for complications. There are some predisposing factors, and the nurse needs to assist patients in identifying possible causes for ulcers, and then we need to teach them ways to alleviate it. Some of the predisposing factors are listed here on this slide, and you can read about them more in your textbook. The one I want to touch base on is H. pylori. That is a bacteria, and it is linked to the development of peptic ulcer, and it's also known to cause gastritis, gastric ulcers, and duodenal ulcers. There are many different protocols for treating H. pylori, but it's generally a combination of an antibiotic, a proton pump inhibitor, and metronidazole or Flagyl. And that combination treatment usually eradicates the H. pylori. But no matter what the cause is, the symptoms are the same. Then there is gastroesophageal reflux, or GERD, sometimes called reflux esophagitis. It's an inflammation of the esophageal mucosa, which is caused by reflux of gastric contents into the esophagus. The medical treatment is similar to the treatment for peptic ulcers. It includes histamine 2 blockers and proton pump inhibitors, which we're going to talk about more. There are also some non-pharmacological measures that we can use to control or prevent and minimize problems with these intestinal disorders, the ulcers and GERD. We recommend avoiding tobacco, avoiding alcohol, avoid eating hot, spicy, or really greasy foods, avoid taking NSAIDs, including aspirin and ibuprofen, or take them with food or in a lower dose. Sit upright, don't eat right before bed, and wear loose-fitting clothing. On to anti-ulcer drugs. There are 7 different groups, and we're going to talk about each one of these individually. Tranquilizers is our first one. They have minimal effect in preventing and treating ulcers, but they do reduce vagal stimulation and decrease anxiety. Anticholinergics and antacids, they relieve pain by decreasing GI motility and secretion. They also act to inhibit acetylcholine and block histamine and hydrochloric acid. Anticholinergics should be taken before meals to decrease acid secretion that occurs with eating. Antacids can slow the absorption of anticholinergics, and then therefore should be taken 2 hours after an anticholinergic medication. Antacids neutralize the hydrochloric acid of the stomach and reduce pepsin activity. You'll recognize these brands very quickly. Sodium bicarb has many different side effects, therefore it's seldom used for peptic ulcers. Calcium carbonate is effective in neutralizing acid, but only 1/3 to 1/2 of the drug can be absorbed, and it can cause acid rebound. And then for antacids that contain magnesium, they are contraindicated in patients with impaired renal function because of the risk of hypermagnesemia. There are some important nursing considerations for antacids that you should know. I would know all the information on this slide. Next, there are histamine 2 blockers, which you should recognize some of these names as well. Pepcid, Zantac. These are used to treat gastric and duodenal ulcers and prevent acid reflux in the esophagus. They block the histamine 2 receptor cells in the stomach, and that reduces gastric acid secretion and concentration. It does have some side effects. I would be familiar with those. And it takes 1 to 2 weeks for its full effect. That's important to know. There are some nursing considerations. I would know everything on this slide, especially what to report, how to separate it from an antacid, and that these people should eat B12 rich foods to avoid being deficient. The next group is a very, very popular group, and you're going to hear it over and over throughout your nursing school. These are proton pump inhibitors, and these, again, should be medications that you recognize. Things like Prilosec, Nexium. These suppress gastric acid secretion by inhibiting the hydrogen potassium enzyme system in the gastric cells. They tend to inhibit gastric acid up to 90% greater than histamine 2 blockers. So that's a huge difference. The bad thing is a minimum of 4 weeks of therapy is needed to fully heal. So if your patient tells you they feel better after a week, you tell them they still have to take it for 3 more weeks to get that ulcer healed. And then the last group that I want to talk about are pepsin inhibitors. The big one to know is carafate or sucralfate, and this is non-absorbable, and it combines with proteins to form a coating substance, and that covers the ulcer and protects it from the stomach acid. It doesn't neutralize or decrease acid secretion. It just protects the ulcer and allows it to heal. It has very few side effects. The only one that I can really think of is constipation. And an important nursing intervention is give it 30 minutes before meals and bedtime. Some other ones is take it on an empty stomach. You want to administer other medications 1 to 2 hours before or after. You need to have the patient report any pain, coughing, or vomiting of blood, and that's really with anything that's for treating an ulcer. And we do want to assess renal function with this medication as well, because it has aluminum in it. And remember, if your kidneys aren't working well, it can have a hard time processing that. Okay, that brings us to the end of this unit, and there are a fair number of drugs for you to work on. Remember, I highly encourage you to look up each of these drugs and make note of anything that I say on the slide related to these medications to help you prepare for the exams. As always, please let me know if you have any questions. I'm happy to help, and thank you for listening.